And I'm going to kind of move quickly past this. This was all lovely presented with the earlier three talks, really talking about the current challenges that we face. Suffice it to say, refractory angina patients are a common, frequent, challenging subset of the patients we take care of. They can be markedly debilitated. We've heard about the impact on their quality of life and actually a significant number of healthcare costs because these patients are repeatedly getting stress tests and angiograms, and there's a frustration because sometimes they also have an incomplete diagnosis. These slides have been shown. I think Tim Henry really demonstrated nicely some of the phenotypes anatomically that can define refractory angina from a coronary angina standpoint. What has been called historically cardiac syndrome X is now evolved into INOCA, ischemia with non-obstructive coronary artery disease. There are more focal areas of ischemia due to obstructive coronary disease, as described as single vessel CTO, then diffuse coronary disease, and then what's called end-stage coronary disease. I would like to highlight that the definition of non-revascularizable really is a subjective definition. I think this is really where we've seen in the last 5 to 10 years a number of improvements in epicardial revascularization, both from a percutaneous and surgical standpoint, including endarterectomies. And so I think it's really important before deeming someone non-revascularizable that they really have gone through a multidisciplinary process with expert interventionalists, particularly those with CTO skills, and cardiac surgeons who have also had experience with endarterectomy and difficult targets. So novel approaches for refractory angina. As you heard about earlier, there's really two parts to this. One is the focus on the neural sensation and processing, and we've heard about spinal cord stimulators, and I'll show just a little bit of data for that. One of the first things to just recognize is that guideline-directed medical therapy, and you just heard in the last talk, we may not always spend a lot of time initially up-titrating anginals. And really, I run a CTO program, and it's the average person number of anti-anginals that are referred to me are typically coming on 1 to 2 anti-anginals. Increasingly, we're starting to see 3 and 4, but just with even that up-titration, we can have a significant impact on patients. Complex PCI, incredibly important, is CTO PCI to really take care of revascularized patients. That would be the majority of our patients who are deemed refractory angina and have previously thought to have no options, really do have epicardial options. In this effort, it's really important to understand the microvasculature. I think you just heard about that a little bit. Coronary reactivity testing, CRT, is a super important part of the diagnostic workup of refractory angina in patients without obstructive coronary disease. That will require the measurement of coronary flow reserve and then focused testing for epicardial vasospasm and microvascular spasm using acetylcholine. And this can now be done in quite efficiently, and it really, as shown by Thomas Ford and Colin Berry in the CORE-MICA trial, really gave us a structured pathway to treat those patients. Dr. Henry spent a tremendous amount of time on developing angiogenesis strategies, both looking at the protein, gene, and cell level that were direct infusions down the coronaries to improve angiogenesis, and has very good phase 1-2 data for that. EECP is underutilized. It's a time-consuming process, but can be very effective. Neurostimulation, we talked about. Drugs, you heard about. And then at the end, I'll speak about kind of novel interventional techniques, as briefly mentioned, the coronary sinus reducer. So here's a case of refractory angina, a gentleman who had a RCA CTO soon after CABG. It was within 1 year. He was very limited. It's a complex total occlusion with really epicardial collaterals to a larger PLV system, not simple for revascularization. His vein graft had occluded, and he was on maximum anti-anginals. He had class 3 to 4 angina on 4 anti-anginals. And he was really also getting rest symptoms at night and was really quite limited. And so his initial cardiologist, thought that he was going to be relegated to medical therapy only. Fortunately, they were able to reach out as they recognized this might have CTO options. And so Using a number of different techniques now, we're able to simplify these procedures, make them more effective. This is just an example of showing a real-time fusion of the CT angiogram. In the CTO segment, there is a gap, and the CT scan will actually fill in that gap, and we can fuse it in the cath lab in real time. And that can tell us where to go. In this particular case, it was very ambiguous where the proximal cap was. We used the side branch to place a balloon, kind of anchor that stiff wire, and then that wire actually knuckled into the subintimal space. We were confident we were in the right architecture, both by fluoroscopy and by CT overlay. This allowed us to advance a knuckle and then use the dedicated balloon called a Stingray balloon to do re-entry, which was relatively straightforward. It was a stick and then a swap with a hydrophilic wire. This allowed us ultimately to then have true lumen access confirmed by IVUS, place several number of stents, and end up with a good angiographic result. Most importantly, this patient had a dramatic improvement in his angina class, reduced to class 1 within a week, and was able to subsequently come off a number of anti-anginals. Just highlight this case because, again, what's deemed to be non-revascularizable really should be discussed with as many expert centers as possible. What about EECP? I'd be curious to understand if this is utilized in India very often. This is a series of cuffs that are wrapped around the distal leg, and the cuffs are inflated serially from distal to proximally in aspects of diastole, ultimately increasing venous return and potentially stimulating angiogenesis. This ends up unloading the heart and leads to reductions in angina. This has actually been studied, data from many years ago, over 25 years or 20 years ago now, demonstrating that there's improvements in angina class, both compared to sham and compared to other medical controls. It is a significant time commitment. A total of 35 hours is required. It requires 1 to 2 hours daily, 5 days per week, 4 to 7 weeks. It's a real investment in time, and in this era, we find that patients are less likely to be committed to that. There is a rejuvenation of this by trying to make these centers also kind of more multidisciplinary, with also doing cardiac educational rehab for risk factor modification during this process, so people are also getting an educational aspect as well. Neurostimulation, this has been briefly discussed, but probably very also underutilized, the use of spinal cord stimulators and electrical nerve stimulation. In our hospital, we're able to now refer these patients to have at least temporary spinal cord stimulation. These patients need to be off DAP. They can just be on aspirin. And this is a way to understand before placing a permanent spinal cord stimulator whether or not they're going to have a clinical response. There are multiple mechanisms of action which you heard about earlier. The data is, again, now this is again about 20 years old, is that a nice trial was done with the spinal cord stimulator being turned on and off, and one could see that there was significant reduction in the number of anginal attacks per day in the nitroglycerin use. So it can be effective, although the durability of this is still to be determined. It may not last for more than a few years, and it is an invasive procedure into the nervous system. So moving on to kind of our next generation of devices that we're excited about, and this is namely the coronary sinus reducer. And in the United States, there is a national trial going on, a multi-center trial, randomized trial comparing the coronary sinus reducer to sham control to understand if it will meet the criteria for FDA approval. This was initially conceived of by Dr. Claude Beck, who was a surgeon from Germany who then came to the United States. And what he recognized after doing a number of animal experiments is that if he ligated the coronary sinus, that he was able to back pressure the heart and actually decrease ischemia induced by experimental stenosis. This was ultimately tried, and this is the device. It's actually a relatively straightforward device to place. It's a 9 French sheath through the jugular vein. The procedure can be done same day. It takes less than an hour. And compared to, for example, complicated total occlusion programs, procedures, the risk of this procedure is likely to be significantly lower. So it's going to be interesting to see how this device evolves. if it has actually successfully met its primary outcome. We do have previous data. The Coursera study was the first trial, and this was published in the New England Journal about 7 years ago now, and compared to a sham control, did show a reduction in control and angina class. It did not have the data for exercise time, and that's really what the FDA is looking for, is a true objective increase in the exercise time, and that's going to be one of the primary endpoints for Coursera 2. This study is going to be about 380 patients up to 35 centers in North America, and it will be a placebo-controlled. Patients will go to the cath lab in the sham control arm and have a sham procedure with IJ access and right heart catheter measurements, and the follow-up clinicians will be blinded to their treatment assignment. The criteria is fairly strict to have true refractory angina patients, 3 to 4 angina class with significant myocardial ischemia in the left coronary circulation. So this is the first trial focusing on obstructive coronary disease. There will be a second group that is actually going to look at ANOCA patients specifically, because now there's some early preliminary data based on IDEs in the United States showing that this actually seems to be effective for ANOCA as well. And so to conclude, what is really important to recognize is that here is our current status of placebo-controlled trial showing an improvement in exercise time, which has really been the most predictive of functional improvement in refractory angina. For angiogenesis therapy, 0, EECP, 0, TMR, transmyocardial laser revascularization, we didn't talk about that, but it's been used historically, 0, neurostimulation, 0, novel drugs, 0, and for Coursera 2 now also 0, there will be 1. And so with that, I'll just conclude with this summary slide, which I thought was a really nice way to summarize this. This is a prevalent disease, 5 to 10% of patients with storyable coronary artery disease. There are a number of emerging therapeutics that may be suitable and efficacious to improve quality of life, which is a critical importance to patients and physicians. But most importantly, we do need standardized sham control trials to best implement to understand these trials' efficacy. And with that, I'll thank you for your attention. Thanks so much.